Thank you very much for the invitation to speak to you today on the optimization of the PK/PD properties of antimalarial drugs. My name is Dr. Joel Tarning, and I'm a professor of clinical pharmacology with the University of Oxford. And I work full-time at the Mahidol Oxford Tropical Medicine Research Unit in Thailand. We work with neglected tropical diseases, and 43% of the world's population are at risk of neglected tropical diseases. Yet only 1% of the new entities from the public market and 1% of the global R&D goes towards entities. So entities are strongly linked to poverty, and many of the diseases are curable with cheap and commonly available medication. Malaria is a very serious disease. Half of the world's population live in areas at risk of malaria transmission, resulting in almost 230 million clinical episodes and over 400,000 deaths annually. Young children below 5 years of age and pregnant women are most severely affected by malaria. And furthermore, the PK/PD properties are very poorly understood for many of the current antimalarial drugs that we use. And that led to that most of the antimalarial drugs were introduced at the wrong dose. The malaria has a rather complicated life cycle. It starts up here to the left with a mosquito blood meal, where the mosquito bites and releases sporozoites into the bloodstreams that within minutes reaches the liver. Within the hepatocytes, these sporozoites mature, replicate, and then are eventually released from the liver cells into the bloodstream. And these merozoites can invade red blood cells, and that's the start of the human blood stage. This human blood stage takes about 48 hours, where the merozoites invade red blood cells, replicate and mature, and then in the end rupture the red blood cells to release new merozoites that can invade new red blood cells. Some of these parasites can also develop two gametocytes, which is then ingested by another mosquito and can lead to transmission further. And it's the human blood stage that we focus mostly on for antimalarial treatments. So this is the schematic illustration of the PK/PD properties of antimalarial drug combinations. On the y-axis, we have parasite biomass, and on the x-axis, we have time in weeks. So the infection starts with the release of merozoites from the liver. About 10 to the 4, 10 to the 5 parasites are released from the liver. These enter the bloodstreams and then invade the red blood cells. Within red blood cells, we have a 10-fold multiplication per cycle, leading to this burst of new parasites in the bloodstream. And this leads eventually to a symptomatic infection, and that coincides with a microscopy limit of detection for parasites at about 10 to the 8 parasites. Commonly, patients wait a day or two before they seek treatment, and when they come in, they have somewhere around 10 to the 9, 10 to the 10 parasites. Malaria patients are treated with artemisinin-based combination therapy, which consists of an artemisinin drug, which is a very short-acting but potent drug, and that pharmacokinetic properties are illustrated here in blue, where you have a 3-day treatment leading to these spikes of drug concentration in the blood, and reducing substantially the parasite biomass during the first couple of days of treatment. The partner drug to this artemisinin-based combination therapy can be mefloquine, piperacin, or a couple of other, lumefantrine, for example. And these partner drug accumulates with each drug administration, and then they are retained in the blood for a longer duration of time. And this leads to the killing of residual parasites. And if the partner drug concentrations are above the minimum inhibitory concentration for long enough to kill off all the parasites in the body, well, then we have therapeutic success. This time where you are above the MIC is also the period called post-prophylactic effect. And if you have an alteration in the pharmacokinetic properties, leading to or a resistance development with an increased IC50 value for the parasites. That can lead to that the drug concentrations fall below the MIC value before the parasites are eliminated from the body. And these parasites can grow back and cause a recrudescent infection. So I'm going to focus on three trials that we have worked with at Moru. So the first trial is the treatment of malaria in young children. So this was 236 children in Burkina Faso with uncomplicated falciparum malaria. They received a standard 3-day DHA piperacin treatment according to the WHO 2010 guidelines. We conducted dense capillary sampling and evaluated these data with nonlinear mixed effects modeling in non-men. The pharmacokinetic properties of piperacin were described by a 3-compartment disposition model, as you can see here. We also had a very flexible absorption model with a couple of transit compartments to characterize the absorption of the drug. These PK parameters were scaled allometrically with body weights, and drug concentrations were linked to the hazard of reinfection. The observed drug concentrations were very nicely described by this pharmacokinetic model, as you can see in this picture here. The shaded area are the model simulations, while the dots are the observed data. And the simulated data coincides very nicely with the observed data, which tells us that we have nice predictive properties of this pharmacokinetic model. So that means that we can use the model for simulation purposes and explore what-if options. So we used this developed model and simulated 1,000 patients per body weight, per kilogram body weight. And this resulted in lower exposure in small children. On the y-axis here is day 7 concentrations, which is a proxy for total exposure, versus the x-axis, which is body weight. And we can see that a lot of the children, the small children, had lower exposure compared to older children and adults. And many of these children were below a previously defined cutoff concentration for therapeutic success. We then used the developed pharmacokinetic model to optimize the dosing so that all patients get an equivalent exposure to piperacin. And hopefully this will lead to a practical and improved dose regimen, giving all patient groups an equal chance of being cured. So with the pharmacometric approach, we show that small children were underdosed for piperacin when given as when treating uncomplicated falciparum malaria. We did a similar thing for severe falciparum malaria, and we demonstrated that young children were underdosed with IV artesunate in severe malaria. So these findings and these results led to revised dose recommendations for dihydroartemisinin and piperacin in young children for uncomplicated malaria, and also for IV artesunate in severe malaria. And this made it into the 2015 guidelines for the treatment of malaria. And these were strong recommendations based on pharmacokinetic modeling. And as far as I know, that's the first time I've seen this language in the WHO guideline, changing it based on pharmacokinetic modeling. The next project I want to talk about is the prevention of malaria in young children. So this study was also done in Burkina Faso, and it was seasonal malaria chemoprevention in young children. The total study size of 741 children, where we had a PK/PD arm of almost 180 children, and a larger PD arm, a pharmacodynamic arm, with 562 children that was used for external validation of our PK/PD model. And data was collected in the high transmission season during August, September, October. And that's also where these children received a standard 3-day DHA piperacin treatment according to the WHO 2010 guidelines. And this 3-day treatment were given once a month for these 3 months of high transmission. Data was analyzed with sparse blood sampling and LCMS, and we used nonlinear mixed effects modeling again to evaluate these results. The data can be seen here. We have piperacin concentrations on the y-axis versus time in days on the x-axis. And this was the month of August, 3-day treatment, and we observed concentration, September and October. And we had both capillary samples and venous samples. And as you can see, the data was relatively sparse. So we used a prior approach by applying the developed model for the children in Burkina Faso that I showed earlier. And then we borrowed that information and fitted these data. And that allowed us to stabilize the PK model so that we can get good predictions for all of these children. So when it comes to prevention of malaria, it's slightly different, but a similar principle. Again, I tried to illustrate that with this illustration. We have total parasite density on the y-axis and time in weeks on the x-axis. The blue spikes here are the DHA treatments, and the red line here is the accumulation of piperacin in the blood and the post-prophylactic effect that piperacin gives. And if a new infection happens around here, these parasites will be eliminated by the residual drug concentrations that we have in the body. And the patient will never know that they had an infection. So in this case, you had sufficient concentrations to eliminate a new infection. But if a new infection occurs later on, the drug concentrations will not be sufficient to eliminate these parasites, and they will grow and multiply every 48 hours until you reach a symptomatic malaria. And here is, of course, an infection lag time from when the infection started in the bloodstream until it was detected by microscopy due to the microscopy detection limit and the growth of parasites. So we try to use this lag time to evaluate and estimate the in vivo MIC value of piperacin. So we collected the recrudescence or the reinfection data from these patients. And this was recorded around these time points. And then we assumed a 5 to 10-fold growth of parasites, and that 10 to the 4, 10 to the 5 parasites would have emerged from the liver at the start of the blood stage. We then used these time points to back extrapolate in time a likely starting point of the blood stage infection. And this here you can see a 5-fold or a 10-fold growth, and with a 10 or 10 to the 4 or 10 to the 5 parasites emerging from the liver. So this gives us a likely starting point for these patients. And if we plot out the piperacin concentrations associated or predicted at the starting point of these infections, we then can see that at the 95th percentile, the higher values that you see here should be close to an in vivo MIC value for piperacin, because that's a concentration which were not sufficient to kill the parasites. The parasites could grow and multiply despite these drug concentrations. So these gives us an in vivo MIC value of between 13 to 17 nanogram per milliliter. We then used to develop PK/PD model to simulate some dosing scenarios. So we looked at the 2010 dose recommendations that was published, that was used in this trial, and also the revised dose recommendation with the higher dose in young children that was published in 2015. So we simulated children between 4 and 20 kilograms. And we wanted to do this to evaluate how the dosing affected the malaria incidence when we're talking about prevention of malaria. In the first case here, we simulated just one round of SMC, given here, a 3-day treatment. And the difference between the red and the blue, the red and the black line here is the difference between the 2010 and 2015 dosing recommendation. And it was a 32% relative reduction of malaria between these two. If we have 3 rounds of SMC during the 3 months of high transmission, we can achieve a 39% relative reduction of malaria with the higher dosing in young children. If we add another round of SMC, giving us a total of 4 rounds of seasonal malaria chemoprevention, that can give us close to 60% relative reduction of malaria. So a huge increase. The last project that I wanted to talk about is a mechanistic modeling of antimalarial drugs, where we applied a pharmacometric approach to develop a mechanistic model for malaria. This was done by using data from an induced blood stage malaria model, where 24 healthy volunteers were inoculated with 1,800 blood stage falciparum parasites, and then all volunteers received a single oral dose of piperacin, either 960 milligram or 640 milligram or 480 milligram, at day 7 or 8 after parasite inoculation. And parasite densities were measured with qPCR. We had dense blood sampling for drug concentrations measured by LCMS. And as I said, we used the pharmacometric approach and non-linear mixed effects modeling to evaluate these data. And this is an illustration of the data that we get. Here is a growth phase where you have a growth of parasites up to the point where you have a piperacin administration, and then you have an elimination of parasites. So by using the data here in the growth phase, we can develop a dynamic parasite model that describes the multiplication of parasites without drug. And then we can add on the data for during the elimination phase to characterize the piperacin-dependent parasite killing. So we used the growth phase data, so that was before drug administration, and we assumed an initial number of circulating parasites, which was the same as the inoculation, 1,800. We also know from previous literature that the fraction of parasite survivors after inoculation is quite low, and we fixed that to 5% based on previous data. We also had previous data on the parasite life cycle length, and that was fixed to 38.8 hours. So not the normal 48 hours associated with wild type infections. But remember that this is a laboratory strain, so this can be alterations in the parasite life cycle, for example. We had qPCR density measurements twice daily, and this is the structural model that we developed. We had a compartment for circulating parasites, which was between 0 and 10 hours, consisting of small rings. These then mature to form large rings, trophozoites and schistons, between 10 and the end of the life cycle, 38.8 hours. And these two compartments are circulating parasites. This is what we see in the blood. But we also allowed for sequestration to occur. And we assume that the sequestration starts from about 29 hours and forward. And that's trophozoites and schistons that adhere to the blood vessel walls. And therefore, they're not circulating in the blood, and we can therefore not measure them. We then have a multiplication of these older parasites that feeds back into small rings. So that's a multiplication rate that is estimated that replenish this compartment with new parasites. And we applied 3 square wave mathematical functions to regulate the movement of parasites between each compartment at specific time period to keep this mechanistic structure of the parasite model. So these 3 square wave functions that we applied give us this kind of shape of the parasite growth. You have total parasite biomass on the y-axis versus time after inoculation. And we can see that you have a period of no growth, and then all of a sudden of a burst of red blood cells releasing new merozoites that can invade red blood cells. And that's the multiplication rate that happens in the end of the life cycle. This dip here is the sequestration. So this is a negative loss of parasites in circulation due to sequestering of parasites. So we could capture this decrease in circulating parasites and the increase in circulating parasites with its dynamic model. We then used the drug concentration data for piperacin and modeled the pharmacokinetic properties of piperacin. And we developed a similar compartmental model as seen before. It was a 3-compartment disposition model with the two transit models in the absorption phase. We then assumed that the drug concentrations in the blood is then directly linked to parasite killing of circulating older parasites, with no effect on the younger small rings from 0 to 10 hours. And this was implemented with an Emax function of piperacin, assuming that you had the same effect on both circulating parasites and sequestered parasites. So with this mechanistic modeling, model, we could capture the growth phase of parasites very nicely here. The shaded area is the simulations from the model, and the dots here are the observations that you see. So the growth was captured very nicely with this mechanistic growth model, and the elimination of parasites were also very nicely captured by this model. It was more difficult to predict the recrudescence of parasites due to the very few individuals actually had recrudescence. So from simulation purposes, you see there's quite wide confidence intervals. But on an individual level, our model did a very nice job capturing both the growth of parasites, the elimination of parasites, and then the recrudescence in some patients. That's seen in patient 6 and 7 here. Growth and then recrudescence. Well, these patients were cured. You had growth of parasites and then a rapid elimination and no regrowth. We then used our developed model to simulate the therapeutic impact of drug resistance. So we applied or added a DHA compartment as well, affecting the parasite, killing parasites here, to see what would happen with drug-resistant parasites. So if we have a DHA resistance associated with CALCH13 mutations, combined with a 3-fold increase in the IC50 values for piperacin, will result in a lower than 85% success rate, which is of course not very good. We also used the developed model to simulate suitable pharmacokinetic properties for an additional drug if we want to use DHA piperacin in triple combinations. And this showed that a drug with about 10 to the 2 killing per life cycle requires at least 2 weeks of effective duration to get treatment success of the drug-resistant parasites that was shown in the first example here. That means both DHA and piperacin resistance needs this type of drug for successful treatment. To summarize, I have 2 minutes left, so I want to summarize this a little bit. And the only way to accurately determine the correct dose regimen is to establish a dose-response relationship through PK/PD modeling. And we have used pharmacometric approaches and nonlinear effects modeling to do this PK/PD modeling. And our research has shown that many of the antimalarial drugs were introduced at the wrong dose, particularly in young children and also pregnant women. And this has undoubtedly contributed to therapeutic failures and the development of drug-resistant parasites. So improving existing treatments and ensuring optimal dosing is essential for the success in the control and elimination of malaria. And we have demonstrated that clinical pharmacology can have a real impact on dosing recommendations in neglected tropical diseases. So I would, of course, want to acknowledge all the children for their participation in these trials, and also thank all the collaborators and colleagues in Burkina Faso and Thailand, and especially Dr. Palang Chotsuri and Dr. Tanaporn Watnakul at the MORE unit for the modeling that was shown here today on piperacin. And of course, also our funders, the Wellcome Trust and the Bill and Melinda Gates Foundation. And with that, that concludes my presentation, and I would be happy to take any questions if there are any questions. So thank you very much for listening.
Okay, thank you, Professor Tarning, for this talk. Indeed, it is very impressive that how your study has been very important and made for evidence on the dosing, recommendation for dosing of the antimalarial, even by the WHO. Perhaps I can ask a question. A lot of these studies were made, with modeling to informed doses. Has the lab also looked at patients on treatment who are not responding to treatment, and therefore it is an ongoing TDM for the treatment of current patients?
Yeah, thank you for that question. We don't usually look at TDM and non-responders because TDM is practically very difficult to do in the malaria setting. Most of the patients that we treat are living in rural areas, and there is no access to TDM. So that makes it very difficult to actually titrate doses or adjust anything. Furthermore, this is the treatment of acute malaria is only a 3-day treatment, so there is very little room to do any kind of adjustments to the doses. But we are, of course, very interested in why patients do not respond well to the treatment, and we've tried to use pharmacometric approaches to understand why some patients are not responding. So we looked at, for example, children, malnourished children, pregnant women and young children, to see if there is any clinical characteristics that can help us to predict what patients are going to be, they're not going to respond to treatment, and therefore maybe start them on different doses.
Okay.
I hope that answers your question.
Yes, thank you, Professor Tarning, and that is a very insightful talk.